Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, welcome to Skin Sync. I'm Victoria Garcia Albea. I'm a nurse practitioner practicing in dermatology outside of Boston, Massachusetts. And I'm here with Dr. Diego Ruiz Dasilva, who has just gotten off the stage giving us a couple of lectures on immunodermatology, focusing a lot on JAK inhibitors and other immunotherapies that we often use in dermatology. So, Diego, can you talk a little bit about phosphorylation in the JAK-STAT pathway for providers who may hear that term and not totally understand what it means?
Of course, yeah. I think it's a good point that we toss that around and we don't always talk about what it means. So it's essentially a way to activate a protein. So by adding that phosphorus, it's activated and it goes on to do the next step in this, assembly line, if you will, right? The machinery of accomplishes some end goal, right? Whether that's inflammation, whether that's again, activating another cell that's going to then go on and kill a microbe or make a red blood cell or do whatever function it's going to be. It all comes down to the phosphorylation, and without that, that cascade cannot go on. And so we bring that up in the context of JAK inhibitors because the JAK inhibitor sits in the ATP binding site for the JAK protein, so that cannot be phosphorylated.
Perfect. I think that helps a lot of us understand what's going on. And so when we hear that term phosphorylation, we'll know what's going on there. Thank you. Can you talk a little bit about the Castle Advance AD test that you mentioned in your lecture?
Yeah, that's something really cool. Hot off the press. Very recently with their validation study published in the JAD, and they leveraged their extensive knowledge with genetic profiling tests, right? So to look at a host of different genes. So they picked 487 genes. They're involved in many different inflammatory pathways. I think there's about 12 different pathways. And then they use a neural network algorithm that basically puts people into categories based on their inflammatory, gene profile. So whether you're a Th2 profile or a JAK inhibitor responder profile. And then they validated this, prospectively. Clinicians were allowed to put patients on whatever therapies they typically would, but they were pre-tested with this Castle test, which, by the way, is non-invasive. It's think of it like a KOH. You're basically doing like a fine scraping with the dull side of a curette to get just a little scale, and then that goes off for them to test. You get a result back in 2 weeks. And then when they followed people over 3 months, they then took metrics, right? Easy 90. Getting to completely clear, 0-1 itch, flare-free status. And the goal there was then see, do we see differences, right? And we do, of course. If they're a JAK inhibitor responder patient and they received a biologic, basically none of them got completely clear. None of them got the optimal itch improvement. Very few of them got an easy 90. And then if they received a JAK inhibitor, they got great rates of all those metrics, right? Versus if they were the Th2 profile, they responded equally as well to either drug, whether they were giving a biologic or whether they were given a JAK inhibitor, presumably because it was more IL-4, 13 driven and those classic Th2 cytokines.
Is it covered by insurance?
So right now, patients are not being balance billed for it. Some insurances are covering it. Others are just like, what is this? Essentially, right? Like with anything new, but no patient is paying out of pocket for it at this time. Yeah.
Amazing. So it sounds like you use it on most of your patients. Is that correct?
Yeah, so most who are in this category where I'm going to choose an advanced systemic, right? So if they're suffering enough or they have enough BSA or they're very motivated and they want an advanced systemic, then I'm using the test. In rare scenarios where I've kind of pre-chosen the drug based on their comorbidity, I might not do it, right? Like if a patient has bad asthma also, and I kind of want to put them on Dupi because I can cover the eczema and asthma, right? You can still do the test and just have that information for the future in case they don't respond, but maybe less important. Or I have a fair number of patients who have psoriatic arthritis or rheumatoid arthritis also have AD, and then I might be putting those patients on upadacitinib so it can cover both diseases, kind of regardless of what the test says. But essentially, you can do it whichever way you'd like.
If a patient comes to you already on a systemic med, maybe you didn't start them, is there still a use for that drug? For that test,
Yeah, for the test.
even if they're on treatment?
Yeah, absolutely. So if the treatment is working inadequately, that would be the reason to test. And then you're going to get what their profile is going to be. And why it's still useful is you say, oh, but now you already know something's not working. Well, not necessarily, right? Because these drugs all have distinct mechanisms, even if even though they're very similar, I guess let's
Hmm.
put it that way, right? And so if you, let's say you scrape someone who wasn't doing great on tralokinumab and it still says Th2 responder, I mean, you can pick one of the other biologics. You could also put them on a JAK because they're going to do as well on any of them. But you kind of have that information versus if it says JAK, like you really should go JAK next. You shouldn't waste your time with more
Okay.
biologics.
Is there an age cutoff for, littler kids? Can you use it in kids
Yeah,
or
so yeah, you can use it in kids. I believe it's 12 and older. I'd have to
12 and older?
double
Okay.
check, but I believe it's 12 and older. Yep.
Awesome. I think I'm going to start using that test. In terms of starting a patient on a JAK inhibitor, are there any questions you ask about their past medical history that give you a little bit of pause? Maybe you dive deeper into their history or anything that you consider as a contraindication?
Yeah, so for the basics, I like to ask like if they've ever had a history of heart attack, stroke, blood clot, or cancer. And it's not saying that if they've had any of those, they're not a good candidate. But if the answer is no, it's a very easy, right? If the answer is yes, then I would want to dig into the history and the nuances. 20 a blood clot 20 years ago after a plane to Singapore, like no big deal. Or even after surgery or some kind of a provoked instance. Family history of blood clots, and you've had a blood clots. Maybe I'm thinking there's a
Mhm.
genetic basis there, right? Like that'd be a reason for pause. Same thing with cancer. You had prostate cancer 10 years ago, not a big deal, but you had stage 4 melanoma. You were on immunotherapy last year, might give me pause. So kind of from that perspective, or even like vascular paths with cardiology issues. If they're not healthy at this stage in their life, meaning like they're not doing the things the doctor wants them to do, whether that's take a statin or a cholesterol lowering therapy, exercise, limit drinking, smoking, and fast food and stuff like that. If you're not taking care of yourself, then I might pause too, just because I'm going to focus on your overall health at that point.
For me, I involve their other care
Yeah.
providers as a nurse practitioner. As a dermatologist, do you also like reach out to primary care or cardiology or onc if they have these other specialties
Yes, I
involved?
will. So certainly in onc, I will. In the other ones, it depends again, right? Because a lot of I've had scenarios with clot history where it's like they don't have a hematologist anymore. Which, by the way, is kind of like the indicator that they don't need
Right.
they don't need one, right?
Yeah.
Because or else they would be followed for that, right? But in onc, even with a history of cancer from 10 years ago, I will. But it's almost like it gives you the answer because sometimes they'll say, "Oh, onc told me they don't need to see me
Right.
anymore." It's like, okay, well now they become low risk. Yeah. So that's simple. But certainly I'll either speak to the rheumatologist or their PCP or a cardiologist for cardiac issues. Something you'll find if you haven't already found is that a lot of times they defer to us. They say, "Oh yeah, I don't know anything about this
I
drug,"
know.
or they say like, "This is not anything I've heard of as being risky," because I think that's not in their kind of vocabulary at this stage.
Excellent. It's reassuring. Last question before I let you go. What diseases are you most excited to treat with JAKs and other systemics that may be currently off label?
Yeah, so I'll give you two answers. The most imminent one is hidradenitis suppurativa. So HS is likely going to have maybe two oral JAKs approved within the next year or two, and that's really exciting because such a debilitating disorder. For me, as a pruritus expert, and love to treat itch because I feel like it impacts patients so deeply. Fascinates me in a different way. I mean, some of them are itchy, obviously, but it's more of the permanent damage that they face, right, with the scarring and tunneling and functional disparament. So I'm excited to see JAKs in that category, and then the further off, potentially never even approved, are more orphan disorders, granulomatous disorders, I'd say.
Mhm.
So, sarcoidosis, as well as generalized granuloma annulare, necrobiosis lipoidica, NLD. These are things I've successfully treated with off-label JAK inhibitors, but sometimes these rare things they don't get the love from researchers essentially to get things approved.
What gave you the confidence to try a JAK inhibitor on those granulomatous disorders where we don't really have any case like studies?
Well, even when they were first approved for AD, there were already a few case reports, like nothing more than that. But basic science wise, they run through interferon gamma,
Mm.
and the interferons are like part of the main class of inflammatory cytokines that are blocked by the JAK1 selective drugs. And so, we kind of had a biological basis for why it would work. And so I was excited to try it out. And then, admittedly, again, to throw the pruritus back in there, these were patients who had these
Mm.
disorders and were super itchy.
True.
So in my mind, it was kind of like, well, I'll make your itch better. I have no idea if your GA is going to disappear or your sarcoid or whatever, and then it did. So it was like proof of concept for me.
Did you try
Yeah.
any topical JAKs on those
Yeah, I've done
patients?
topical jacks on many of those patients as well. It works well. It just depends on how limited,
Yeah.
like, because if it's
Yes.
generalized, then it becomes hard to put the topical all over. They do work very well.
Awesome. Do you think this one I didn't prep you for? I know JAKs don't suspend well for like
Yeah.
intralesional. Do you think we're going to ever see intralesional JAKs? Because wouldn't it be great for like localized skin diseases to use it intralesionally?
Yes, absolutely. So I do think we're going to see it at some point. I don't have any insider information, but one of my close friends in derm, Dr. Leo Wang, is a MD PhD at Penn, and that's his area of study for the alopecia world. And from at least my last conversation with him, it looks like they're progressing really positively in that direction. So
Amazing. I think
that
that'd
is
be
very
a game
exciting.
changer.
Game changer, 1,000%.
Well, thanks a million, Dr. Ruiz Dasilva, for joining us here on Skin Sync. I appreciate your conversation.
Yeah, thank you so much for having me. Pleasure to be here.
Thanks for tuning in to Skin Sync. Don't forget to subscribe to Skin Sync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.